Thank you for the invitation. I work in St. Gallen as clinician in palliative care and also oncology. These are patients you and I see every day, patients who look not cachectic, who are pre-cachectic, patients obviously cachectic, and patients refractory cachectic. You know this slide. You see pre-cachexia, patients do not have yet weight loss but start to have problems with cachexia. Patients having cachexia have weight loss and sarcopenia, and patients in refractory cachexia tumor is proactive, not treatable, not influenceable, and in cachexia, patients have sarcopenia. Now, do you see this patient in your practice? If you do CT scans of your patient, you see the decreased muscle mass. And this is a very nice slide from Canada with colorectal cancer patients. I showed you one example, BMI 24, 55% of your patients have sarcopenia. So you see this patient in your practice even though you don't see them. Why does it matter? Why should you care about sarcopenia and cachexia? Because these patients live a lot shorter. This is a wonderful study from the ARCA trials of 39 trials, 20,000 patients, convincing data. And you see that overall survival and PFS is decreased. You see here also on the slide, if you don't want to get cancer, be thin. If you have cancer, try to be obese at that point, because you will live longer if you have more fat. This is, if you add to BMI also weight loss, you see that the BMI is prognostically favorable, but also weight loss is prognostically not favorable. This is also a large study from 8,000 cancer patients, and survival depends both on weight loss and on BMI. And Lisa Martin proposed a grading system on with stage 4, with grade 4, 3, 2, 0, and 1. And in gastroesophageal cancer, you see that these grading, not the same colors, matter to your patients. So for your practice, measure and monitor weight loss, measure and monitor BMI. It matters also to patients' quality of life. These are nice data from symptom assessment scales. The top 2 symptoms are tiredness, physical fatigue, mostly physical fatigue, anorexia. So your patients suffer symptomatically from cachexia. Also, your patients in your practice, they have more anti-cancer treatment toxicity. I updated this slide by 2 recent data from GI stroma tumor, from esophageal gastric cancer, and an older study from colorectal cancer. Your core business, your patients will have more toxicity if you don't see they have weight loss or low BMI, or even better, have sarcopenia. You should probably treat those patients for dosing her differently than patients with normal, without cachexia. Also for the surgeons under you, it matters. This is a summary of patients where they looked at the question, do they have in gastrointestinal surgery more or less complications and more or less survival time, a risk of survival time. They looked at the diameter of the psoas and saw that it's not correlated with survival, but the mass of the psoas with this nice picture correlated very well with the survival during and after gastrointestinal surgery. So the question is now, I convinced you it matters. You see this patient, was it sarcopenia? Sarcopenia is simply loss of muscle mass, too many causes. In practice, we see often hypogonad patients. I measure in men free testosterone, give it back to patients. Physically inactive patients lose muscles. Corticosteroids eat your muscles, thyroid dysfunction, but also age-related sarcopenia, the muscle stem cells, the myogenic program, getting older, and your patients need more training, and the training is less effective to keep the muscles. And cachexia is one of the major reasons for sarcopenia. What is cachexia? Cachexia, as you also know well, an old definition, is per definition a loss of muscle mass. Per definition, nutritional intake does not fully reverse the syndrome. I convince you in a few minutes about why. But nutritional intake and support is important in cachectic patient. It's caused by a dual pathophysiology, by decreased intake, by metabolic changes, and your patients get physically decreased, so they have functional impairment. That's cachexia. So the patient with low BMI who jogs more than you is not cachectic, but the patient who loses muscles, gets declined, and has problem with appetite is the cachectic patient. If you look at the question, why is causing cachexia, what are the mechanisms? That was a question you asked me to look also into it. First, there is some problems of the mouse or the preclinical models. These people looked at the question of preclinical data and if the same data have been replicated by humans. And the critical mark is animal studies have to be replicated in humans. But you see here also that the two major drivers of cachexia are inflammation, like the TNF receptor adapted protein, but also muscle problems in your patients. These are the main kind of drivers for cachexia. You see the TRAF, you see also the AT2 weak-knit protease system, but also this MyoD and PAX7. I'll come to that in a minute. The MyoD system of the muscle genesis and PAX7 satellite cells. If you look at cancer patients never been treated before, these are data from Canada, from Alberta. They looked newly diagnosed cancer patients and looked at the CRP, at the neutrophil lymphocyte rate, and also albumin, and you see that patients with cancer have increased CRP, decreased albumin, and the NL ratio gets down. And if you look further, you see also other markers like IL-6, IL-8 are different, and maybe we need cytokines to differentiate better pre-cachexia and cachexia. But in clinical practice, I think we should measure inflammation to further make decisions. Now, if you look at heat maps of tumor samples, you see here heat maps of two different samples, normal and on the right side tumor. You see the IGF binding protein 3 is red upregulated, it's logarithmic scales from green to dark red. And you see also here CRP is upregulated in both tumor sites. Then you ask the question, why does it matter? If you look at the muscle cells, if you look at the myogenic program and also the protein degradation, you see that IGF binding protein 3 will decrease the myogenic program, dose dependent, but also will increase protein degradation, also dose dependent. So inflammation matters on the muscle directly. Now if you look at CT scans, we had a wonderful presentation on imaging. You can see that the muscle starts to build in fat. It's called myosteatosis or low muscle attenuation. That's a feature of cachexia. So the muscle changes his integrity, and it matters also in terms of disease-free survival in melanoma, various tumor survival, and also in pancreatic cancer, both survival and recurrence-free survival, and also in patients with colorectal cancer, elective surgery, it matters as an independent predictor of survival and other reasons. So sarcopenia, inflammation, muscle attenuation are independent predictors of survival. If you look closer at the muscle, you see here a slide on a classical slide on the myostatin activin signaling pathway, muscle protein synthesis, but also protein degradation. There's a nice ASCO poster just this year where they asked the question if cachexia-related genes, will they affect prognosis of colorectal cancer patients with bevacizumab-based chemotherapy? And yes, the ACVR2B mutant patients, they have clearly decreased survival compared to those not mutated, and they have a nice discovery and control cohort to convincing them. If you look further in the muscle, there's a study from Edinburgh. They looked at GI cancer patients. They are surgeons, so they get muscle biopsies, and they looked at myosin heavy change and dystrophin, and could also show the patients who have these changes in the muscle have a lot less survival than the others. So in summary, muscle structural changes happen in cachectic patients. Now you're sitting there, mostly a few clinicians, how can you interfere with these complex mechanisms? Very simple, screen the patients. You have to look at your patients' weight loss, track your weight of your patients, ask them how they eat, and look for a BMI, calculate it. You have nice apps in your pocket for BMI. If you do that, you do the most important thing to treat these patients. Second, assess the patients for the main domains of cachexia, nutrition intake, objective, subjective measurements, nutrition impact symptoms, muscle mass, performance status, and degree of inflammation. It's very simple. You see here also the brand new ESPEN guidelines, which are in print now. I hope I was allowed to do that. They will come up in a few weeks. I was quoted on them. You see here, recommendation is strong, evidence low. That shows that clinically it's obvious we should do that. These are the domains for cachexia on our lens oncology paper. Cachexia is about reserves, about intake, about inflammation, catabolic drive, and decreased function. It's very simple. In practice, you know this slide I showed you last year. What do? I look for weight loss. I palpate my patients always pre-tibial if they have edema. If my finger go down 3 millimeters, they have about 500 grams. If they go down 5 millimeters, they have about 2 or 3 kilograms. So they might be weight still, but they lose muscle. Or I go for a CT scan, which is not a routine. I look for two-day diet diary. I ask for proteins, for calories. I ask the symptoms of the patients, and I go for second nutrition impact symptom management. I'll show you in a minute. I look for the cancer dynamics, and I always measure CRP in my patients to get a feeling of the tumor dynamics of the inflammatory status. And I check the physical function. I might also do a get up and go test for the patient to get a feeling of them. And then I can decide on the phase of the patient and also the goals of the intervention. 2 slides, you know. In clinical practice, very important to assess secondary causes for decreased nutritional intake, dietary mistakes, neglect for maintenance of nutritional intake, symptom impact symptoms, constipation. That's daily bread, which is very important. Inflammation, rule out infections. I did some work on check if we have new data on procalcitonin, but the data are not convincing. So the conclusion here is if you have a low than normal procalcitonin and increased CRP, the negative predictive value for infection is probably high. So you could use the ratio probably in clinical practice better than PCT alone. That's what I'm doing right now. Also clinical, look for a steep increase of CRP if the patient might have infection or not. So what is the management of our patients? You see on the left side the 4 domains of cachexia: decreased muscle mass, nutritional intake, inflammation, tumor dynamics, neurohormonal, neuromuscular, and emotional cognitive function. On the right side you see all the interventions. So we learned from the cachexia pathogenesis, from the mechanism. It's about intake, it's about function, about symptom control for nutritional impact symptoms. We need new drugs for cachexia. We need an anti-cancer treatment to hold the tumor. We need also a patient who is motivated to understand. A lot of cachexia management is education. The patient understands, I have to do training even though I don't want. I have to make muscle strength. I need to zip the strings. That's a lot about understanding of patients. And we heard about the randomized controlled trials of early integrated palliative care, and a lot of those interventions, there's an update from Jennifer Timmel at ASCO, a lot of this intervention is understanding of the patients about the illness, about coping, about being participants in the care of the patient. The new cohort of the study, presented at ASCO by Jennifer, includes also GI cohort study, GI cohort not only non-small cell lung cancer. Now, what means nutritional counseling? That's the ESPEN guideline, is here again. Strong recommendation, moderate evidence, and it's quite simple. I showed you on the bottom what I do. I tell my patients always the same: many small meals, breakfast, after breakfast, at 9 o'clock, before lunch, at lunch, after lunch, at 4 o'clock, at dinner, after dinner, when you go to bed. Patients say, what do you mean, Dr. Strasser? That's clinical practice. Cognitive control of eating, proteins, fat, change habits, oral supplements if possible. And you see here the protein intake, 1 gram to 1.5 gram per day. It's the recommendation. Now in practice, it's not that easy. If you have a patient with body weight of 80 kilograms, he might have a lean mass, which is quite different, and his protein requirements might be quite high or quite low, depending on the muscle mass behind his BMI, as I showed you before on the muscle scans. That means in practice, clinically monitor your patients for physical function is important, and what I tell my patients, eat proteins, proteins, proteins. That's as simple, and if they can do it and increase function, then you do a good job. But I would be careful to base your doses of your nutritional intake, your proteins, on the body weight alone. Per nutrition, the evidence is relatively scarce. There is a Cochrane review last year, and there's some new data coming up, but all of them are phase 2 studies, and it's not easy to tell in which patients give nutrition. What we would need is a randomized, placebo-controlled nutrition trial. If there's somebody from a nutrition company in this room, this would be a nice study to perform. Why is nutrition so difficult in cancer patients? That's a relatively difficult slide. It was done in Edinburgh, and they studied 8 cachectic pancreatic patients and 7 controls. They gave them IV phenylalanine and tyrosine over 8 hours. They sipped phenylalanine, essential amino acid, every 30 minutes. After 4 hours, they started feeding. Now what you see here on the baseline, the protein turnover, the protein synthesis, the protein breakdown in cachectic patients is higher than in controls. And the more CRP the patient have, the more pronounced was that. So patients with cachexia, they produce more proteins and they have a lot more decrease in protein. Now if you feed these patients, you see here that the protein breakdown decreases both in cachexia and control. So if you feed the patients, the patient with cachexia stops the breakdown and the net turnover, the net balance stabilizes, the patient even gets better. But the problem is the protein synthesis is unchanged in cachexia, but in control it goes up. So that means if I give a patient a parenteral infusion of nutrition, the breakdown might stop, but the patient cannot build proteins because he has an inflammation and active cancer. So, cachexia patients and controls have a comparable anabolic response to feeding, but patients achieve it only by reduced protein breakdown, and it means that the anabolic resistance might be less an issue in cachexia than thought. We need anti-tumor and anti-inflammatory treatment. One slide, you're oncologists, and I study from PETL showing in NSCLC patients, those patients who have good response, they get more weight gain, those with less response, less weight gain. One slide, very simple. Now exercise. Also here the evidence is relatively scarce. There's a nice review, Cochrane review from Matthew Maddox. They looked for RCTs who had the cachexia definition, but they didn't find data relevant for cachexia. They did a huge job. Now, the potential for exercise to impact positively muscle mass and strength is here, and also there's data that physical exercise improves inflammation, improves physical function, and our ESPEN guidelines show strong recommendation, high evidence, but for overall physical exercise, not for advanced cancer patients. Why should it work? If you look at the muscles in mice, you see that mice have PAX7 is upregulated and reduces muscle mass and fiber size, and the regenerative potential of fibers is decreased in cachectic patients. And if you do exercise, then you see that the PAX7 overexpression is downregulated and the muscle fibers switch from left to the right, which means more muscle fibers and bigger size. So moderate exercise can improve your muscles. Now, be pragmatic, I come to the end on the drugs. For cachectic patients, corticosteroids, you can use them, you know this slide. Now we have also the ESPEN guidelines. There are 2 randomized controlled trials who show that corticosteroids improve appetite and fatigue, but don't give these drugs more than 1 or maximum 2 weeks because you will eat the muscles of your patient. And that's also the recommendation. We put here 1 to 3 weeks, but 1 week is better. Prokinetics, we have a weak recommendation, moderate evidence, and in clinical practice, very few side effects. Almost all of my patients get 4 times a day prokinetic with a lot of education. It's not for nausea, it's for prokinetics. Fish oil, EPA, a weak recommendation, low evidence in practice, often poorly tolerated. We recommend to try it. You need tricks like freezing them and make different colors and just try to eat it even though you don't want to. Progestins, high evidence, a weak recommendation. In practice, always never used. I prefer education of patients rather than give a drug which stimulates appetite but is risky. These drugs is insufficient. We could not give a recommendation. We need more clinical trials. The MENAC trial, an international study, is running with physical exercise, strength training, NSAIDs, EPA, and nutritional counseling. And the emerging drugs, you know this slide. What I added is all the references for enemoreline. That's the only thing which happened, that we have data from enemoreline. Enobosarm was not published yet. And the antimyostatin we are waiting, anti-L1 we are waiting for the data. Enemoreline, showed increase of body weight, increased muscle mass, increased fat mass. So the patient eats more, gets more fat. So wow, no difference. We don't know toxicity outcomes. Then the hand grip strength did not change, but they did not measure physical function or leg strength. And on the symptom side, there's now a composite analysis of the data by David Currow. And you see that symptom improvement is only in patients with low BMI. So my conclusion, cachexia and sarcopenia are frequent in GI oncology. The therapeutic strategy should target the domains, and we need a mechanism-based intervention by multi-professional people. We need more data from your clinical GI trials incorporating sarcopenia, cachexia variables, and we, cachexia people, need more research. Thank you very much.